osimeter in untreated EGFR mutated advanced non-small cell lung cancer. Definition: lung cancer starts when cells of the lung become abnormal and begin to grow out of control. As more cancer cells develop, they can form into a tumor and spread to other areas of the body.
Understanding non-small cell lung cancer. When you inhale, the lungs transfer oxygen from the air to your blood. They also take carbon dioxide from your blood and get rid of it when you exhale. Lung cancer is a disease caused by the unchecked growth and spread of some cells from the lungs. Non-small cell lung cancer is one of two major types of lung cancer. The other one is a small cell lung cancer. The most common subtypes of non-small cell lung cancer are adenocarcinoma, squamous cell epidermoid carcinoma, and large cell undifferentiated carcinoma. Non-small cell lung cancer is the most common type of lung cancer and affects about 8 of every 10 people with lung cancer. There is no single cause of non-small cell lung cancer. Like most other adult cancers, non-small cell lung cancer is caused by a buildup of damage to cells. Over many years, this damage changes some cells so that they can grow, multiply, and spread unchecked. If a cancer isn't completely killed or removed, it can spread to other organs. A cancer that is spread to another site is called a metastasis. There are two types of risk factors for non-small cell lung cancer: risk factors that you can change, and risk factors that you can't change. Risk factors that you can change are smoking, being exposed to secondhand smoke, radon like in a basement, asbestos by working in mines, mills, textile plants, or with old insulation, uranium and other radioactive materials, chemicals like arsenic, coal products, and diesel fumes, and arsenic in drinking water. Risk factors that you can't change are air pollution, having had lung cancer, prior radiation therapy to the lungs, and parents or siblings with lung cancer, especially if young when diagnosed. The symptoms of non-small cell lung cancer are not specific. Possible symptoms are a cough that doesn't go away or gets worse, coughing up blood, rust-colored spit, hoarse voice, unexpected weight loss and loss of appetite, shortness of breath, feeling tired or weak, a lung infection such as bronchitis or pneumonia that won't go away, and wheezing with no known cause like asthma. Symptoms that non-small cell lung cancer has spread to other organs are pain in the back or hips if it's in those bones, headaches, weak or numb arm or leg, dizziness, balance problems, and seizures if it's in the brain or spinal cord. So far, researchers haven't found any drugs, vitamins, herbal remedies, or alternative medicines that can help prevent lung cancer. The most important thing you can do to lower the risk of non-small cell lung cancer is don't smoke cigarettes, cigars, pipes. Other things you can do: avoid secondhand smoke, avoid radon and other chemicals that can cause cancer, eat a healthy diet. Having a small cancer that hasn't spread outside the lung increases survival. The 5 basic ways to treat people with non-small cell lung cancer are surgery, radiation therapy, chemotherapy, targeted therapy, and immunotherapy. Which options are best for you will depend on factors like your tumor type, size, location and spread, tumor molecular makeup and other test results, symptoms, age and overall health, and preferences. When you meet with your doctor, be sure to ask lots of questions. For example, what are the goals of this treatment? What are its possible side effects? Explain your worries and wishes. Get a second opinion. And ask if there are any clinical trials you could join. Ask your doctor if your cancer can be cured. New treatments have helped people with non-small cell lung cancer live longer than ever before.
Application in medicine. Osimertinib is an oral third-generation irreversible EGFR TKI that selectively inhibits both EGFR TKI sensitizing and EGFR T790M resistant mutations with lower activity against wild-type EGFR1.
Hi, I'm Dr. Jack West, medical oncologist in Seattle, Washington. And there's been a new advance in the management of EGFR mutation positive advanced non-small cell lung cancer. And what's particularly interesting is we now have a new option for a subset of patients for whom we really haven't had a well-studied or effective treatment, at least nothing that people have really broadly known about. For more than a decade, when we've talked about EGFR mutations, we've really been talking just about the two common activating mutations, which are known as an exon 19 deletion or an L858R substitution on exon 21 of the EGFR gene. And together, they account for about 88 to 90% of mutations. So clearly, that's the majority, but that also leaves 10 or 12% of patients who have a detected EGFR mutation that doesn't fit into these categories and for which we really haven't had a great sense of what to do. We typically will maybe try to empirically give an EGFR inhibitor, but we've seen varied success and really haven't had a clear sense of which of these mutations actually respond well to which of the inhibitors. So there was an important contribution to the field in a publication by James Yang and colleagues, and it was in Lancet Oncology 2015. And in that, they they aggregated the results with afatinib from several studies that allowed patients who had not just the common activating mutations that we knew a lot about, but the rare uncommon mutations as well. And they separated out the patients with these uncommon mutations to see if they could figure out any clear patterns. They separated them actually into three different groups. One of the groups was those who started out with the T790M mutation, which we know is involved with acquired resistance and is the most common mechanism for patients with a common mutation developing acquired resistance. That tends to be associated with T790M in 50 to 60% of patients, but a minority of patients will have T790M right from the time of diagnosis, just about 2% or so. And unfortunately, afatinib didn't seem to work that well for them, nor did it work well for the about 3% or so of patients with an exon 20 insertion, which is another uncommon but recurring theme that we do see if you see a lot of patients with lung cancer and do a lot of testing for EGFR. But unfortunately, afatinib and historically other EGFR tyrosine kinase inhibitors have not been particularly effective for these exon 20 mutations either. On the other hand, there was a third group, and that really included a few mutations that, though considered uncommon, together account for about 6% or so of all the EGFR mutations out there. And those were called G719X, X being any of several amino acids, L861Q, and the third one is S768I. And if you look for enough EGFR mutations, you do find patients who have these mutations. And the results of that pooled collection, that pooled analysis of afatinib trials and uncommon mutations showed that the patients who had these mutations had about a 75% response rate to afatinib, and that the progression-free survival was in the same range of many, many months, approaching a year or so, as what you would see with the more common EGFR mutations that we've been studying for more than a decade and have a lot of experience with. And so on the basis of this collection of data, the FDA in January of 2018 has approved afatinib for these uncommon EGFR mutations. The importance is, first of all, this doesn't mean that every kind of EGFR mutation will respond to afatinib. As I mentioned, the T790M and exon 20 insertions don't follow that pattern, although we do have a particular treatment with osimertinib that is effective for T790M, and there are studies looking at novel EGFR type tyrosine kinase inhibitors for exon 20 insertions, but that's still investigational. But for the subset of patients who have these uncommon mutations that I mentioned, afatinib is now an officially approved approach that should be readily available for them, and we can be very hopeful they'll have a very good response. Another implication of this is that there's various ways of testing for EGFR mutations, and some labs only look for the most common ones, like exon 19 deletions and L858R substitutions and exon 21, maybe T790M as well. But you're only going to find these other uncommon mutations if you look for them properly. So the panels, whether it's by PCR, for instance, you have to include these mutations in the panel to find them. And of course, broader genomic sequencing will detect them as well. But I think that this is going to be a big benefit for what is still a small population of patients. But if you do have patients with these mutations, or if you are a patient with them, it is a big benefit. And we will also now be able to study them much more carefully in the future and potentially find subsequent treatments that will work for them. So I hope you find that interesting, and I welcome your comments and questions. Thanks.
Pros. A consistent benefit of osimertinib over standard EGFR TKIs with respect to progression-free survival was shown across all predefined subgroups that were assessed.
The pathophysiology of non-small cell lung cancer. Lung cancer is the leading cause of cancer-related deaths in the Western world. Non-small cell lung cancer, or NSCLC, accounts for approximately 85% of all lung cancers and is divided into three subtypes: adenocarcinoma, or AC, squamous cell carcinoma, or SCC, and large cell carcinoma. The different types of NSCLC develop in different locations of the lungs. Adenocarcinomas develop in the peripheral portions of the lungs in alveolar type 2 cells. Squamous cell carcinomas develop near the center of the lungs in mucociliary epithelial cells. And large cell carcinomas may occur in either location with squamous and glandular features. Risk factors associated with NSCLC include smoking, secondhand smoke, occupational carcinogens, and diet, nutrition. Smoking remains the leading and most preventable cause of lung cancer, accounting for 80 to 90% of cases. According to current views on the carcinogenesis of NSCLC, the transformation of a normal lung cell to malignant carcinoma requires the accumulation of multiple genetic and epigenetic alterations. It is believed that early alterations are caused from point mutations or chromosomal deletions that inactivate tumor suppressor genes, or TSGs. A TSG loss that is thought to occur in 80% of NSCLC cases is that of P53. P53 is a transcription factor for various downstream targets that are involved in cell progression, DNA repair, and regulation of apoptosis. Mutations to P53 hinder its normal tumor-suppressing capabilities. Thus, DNA damage remains unchecked, faulty cells proceed through the cell cycle, and apoptosis is evaded. This creates a genetic condition in which the cell is more susceptible to further mutations. Another critical alteration that occurs in the development of NSCLC is the activation of oncogenes. In 50 to 90% of NSCLC cases, the epithelial growth factor receptor, or EGFR oncogene, is upregulated. The binding of EGF activates signaling cascades that modulate the transcription of genes important in cell proliferation and resistance to apoptosis. In the majority of lung cancers, the activation of telomerase, a telomere lengthening enzyme, is detected. Telomeres are hexameric nucleotide repeats that protect the ends of chromosomes from unraveling, analogous to shoelace tips. Telomeres shorten with each cell division, limiting cell proliferation. By extending the telomere, telomerase contributes to prolonged cell survival. In order for premalignant cells to progress towards malignancy, cells must be able to escape programmed cell death. Additionally, in order to sustain growth and metastasize, tumor cells require an adequate blood supply and consequently promote angiogenesis. Tumor cells promote angiogenesis by producing vascular endothelial growth factor, or VEGF. VEGF binds to VEGF receptors on endothelial cells, inducing the formation of new blood vessels from pre-existing vasculature. This vasculature sustains tumor growth. The accumulation of these and other genetic and epigenetic alterations may randomly occur throughout the genome and eventually lead to NSCLC. As NSCLC advances, the tumor may spread to other areas of the lung and to other organs.
Cons. Adverse events of grade 3 of higher were reported in fewer patients in the osimertinib group than in standard EGFR TKI group, plus cardiac effects. Issue applied in Ecuador. The survival rate at 18 months was 83%, 95% CI, 78 to 87, with osimertinib, and 71%, 95% CI, 75 to 76, with standard EGFR TKIs.
Hello and welcome to another episode of Daily News. Today's video is about survival statistics for lung cancer. Lung cancer survival. Find out about survival for lung cancer. People ask us for this information, but not everyone with cancer wants to read it. So, if you aren't sure whether you want to know at the moment, you can come back to it later. These are general statistics based on large groups of patients. They can't tell you what will happen in your individual case. No one can tell you exactly how long you'll live with lung cancer. It depends on your individual situation, treatment and level of fitness. Your doctor can give you more information about your own outlook, prognosis. or you can talk to the Cancer Research UK nurses on free phone 0808 800 4040 from 9 to 5, Monday to Friday. Survival for non-small cell lung cancer by stage. There are no UK-wide statistics for non-small cell lung cancer survival. The following statistics come from the 2007 Lung Cancer Staging Project. This worldwide study collected data about lung cancer on more than 81,000 patients from 19 countries. There is a range of statistics for each stage because for some patients the stage was based on the results of scans and tests, and for other patients the stage was found during surgery. Stage 1. Stage 1 non-small cell lung cancer is divided into two stages, Stage 1AM and 1B. For Stage 1AM non-small cell lung cancer, between 58 and 73 out of every 100 people, 58% to 73%, will survive for 5 years or more after diagnosis. For Stage 1B non-small cell lung cancer, between 43 and 58 out of every 100 people, 43% to 58%, will survive for 5 years or more after they are diagnosed. Stage 2. Stage 2 non-small cell lung cancer is also divided into Stage 2AM and 2B. For Stage 2AM non-small cell lung cancer, between 36 and 46 out of every 100 people, 36% to 46%, will survive for 5 years or more with treatment. For Stage 2B non-small cell lung cancer, between 25 and 36 out of every 100 people, 25% to 36%, will survive for 5 years or more after they are diagnosed. Stage 3. Stage 3 non-small cell lung cancer is divided into Stage 3AM and Stage 3B. For Stage 3AM non-small cell lung cancer, between 19 and 24 out of every 100 people, 19% to 24%, will survive for 5 years or more after they are diagnosed. For Stage 3B non-small cell lung cancer, between 7 and 9 out of every 100 people diagnosed, 7% to 9%, will survive for 5 years or more after they are diagnosed. Stage 4. For Stage 4 non-small cell lung cancer, only between 2 and 13 out of every 100 people, 2% to 13%, will survive for 5 years or more after diagnosis. It can seem illogical for Stage 3B cancer to have 5-year survival rates from 7% to 9% and Stage 4 from 2% to 13%. This is because the staging system only looks at the extent of the cancer. It does not look at the specific types of cancer. So the Stage 4 group may include more people who have slowly growing cancers or cancer that responds very well to particular treatments than the Stage 3 group. Survival for small cell lung cancer by stage. There are non-UK-wide statistics for small cell lung cancer survival. The following statistics also come from the International 2007 Lung Cancer Staging Project. This study used the TNM staging system to give the following statistics about survival based on the stage found by scans and tests. The project included more than 8,000 patients with small cell lung cancer. Stage 1. Stage 1 small cell lung cancer is divided into Stage 1AM and 1B. For Stage 1AM small cell lung cancer, almost 40 out of every 100 people, almost 40%, will survive for 5 years or more after diagnosis. For Stage 1B small cell lung cancer, around 20 out of every 100 people, around 20%, will survive for 5 years or more after they are diagnosed. Stage 2. Stage 2 small cell lung cancer is also divided into Stage 2AM and 2B. For Stage 2AM small cell lung cancer, almost 40 out of every 100 people, almost 40%, will survive for 5 years or more after they are diagnosed. For Stage 2B small cell lung cancer, almost 20 out of every 100 people, almost 20%, will survive for 5 years or more after diagnosis. The survival rates for Stage 2AM seemed to be higher than for Stage 1B. Researchers think this is because the study had very few patients in the Stage 2AM group. They suggest that those statistics may not be so reliable as the others.
Conclusion: osimertinib showed efficacy superior to that of standard EGFR TKIs in the first-line treatment of EGFR mutation-positive advanced NSCLC with a similar safety profile and lower rates of serious adverse events.
For patients with advanced non-small cell lung cancer and a mutation in the epidermal growth factor receptor, or EGFR, first-line treatment is with an EGFR tyrosine kinase inhibitor, an EGFR TKI. Some patients initially have a good response to this treatment, but over time the cancer progresses in most. In up to 60% of patients who have a recurrence of lung cancer, a point mutation in the gene coding region T790M has been identified. The presence of this mutation is associated with reduced binding of the EGFR TKI therapy to the receptor, leading to less inhibition and to cancer progression. Osimertinib is an oral irreversible EGFR TKI that is selective for both EGFR and T790M resistance variants, with activity against metastases to the central nervous system. The international open-label AURA-3 trial included 419 patients with T790M positive advanced non-small cell lung cancer who had progression of cancer after prior treatment with EGFR TKI therapy. 144 of the patients, or 34%, had asymptomatic CNS metastases. Patients were randomized to receive a daily dose of osimertinib or intravenous platinum pemetrexed chemotherapy every 3 weeks for 6 cycles, followed by maintenance pemetrexed. The primary endpoint was investigator-assessed median progression-free survival, which was 10.1 months in the osimertinib group, as compared with 4.4 months among those treated with IV chemotherapy. The hazard ratio, 0.30, was statistically significant. A subgroup analysis of the patients with CNS metastases showed a median progression-free survival of 8.5 months in the osimertinib group, as compared with 4.2 months in the IV chemotherapy group. Patients in the osimertinib group had diarrhea, rash, and dry skin. Cases of severe myelotoxicity were less common with osimertinib than with IV chemotherapy. The authors conclude that in patients with T790M positive advanced non-small cell lung cancer and prior EGFR TKI therapy, treatment with osimertinib resulted in significantly longer progression-free survival than did IV platinum pemetrexed chemotherapy. Full trial results are available at nejm.org.